Tonight, our program is going to consist of two parts. The first part is going to be our new friend Mike McLaughlin, who will be sharing what the organization Musa Masala is all about and the role that they've played with the Wongchhu Sherpa Memorial Hospital in Nepal, and how he and Dr. Anumesh Dahal met over Dr. Dahal's idea to create opportunities for dental care in regions where none was previously available, and how that idea has blossomed into the dental camps that are currently run in pursuit of this mission. So with that, I will turn it over to you, Mike.
Okay. Thank you, Gina. Um, Gina, thanks so much for having us here. This is pretty exciting for everybody at Musa Masala and for everyone who's been involved with the Wongchhu Sherpa Memorial Hospital, which is actually came originally from a Wilderness Medical Society trek to Everest Base Camp led by Dr. Luann Freer. When our good friend Wongchhu Sherpa died in 2015, his dying wish was to have a hospital built in the Camding area where he lived. And so with Paul Arbach and Eric Johnson, Luann Freer, and the members of the Wilderness Medical Society, we started raising money for this hospital. Musa Masala was founded on the idea of raising money for the hospital through an original book that we wrote called Musa Masala, Mountain Girl of the Himalaya. I think we're actually going to give one away here to the most luckiest and luckiest person this evening. What I would like to do now is just show a quick video of what Musa Masala does, and then I will do another quick roundup on how the dental camps came into being, and then Anumesh will take the rest of the evening. So, yeah, Gina, if you want to show the video, we're ready to go.
I think I have to share a different window. I was hoping it would just pull up. Hold on.
Yeah.
I
But
thought it
so yeah, so this is just like a 2 minute sort of promo of the different things that we do, along with the dental camps we do. We also are very involved in the indoor climbing scene in Nepal, and we have put on pretty much the only climbing competitions in the country since the COVID lockdown. So we're really trying to give the young athletes a chance to compete, and also with being able to compete internationally and grow the sport in Nepal. We are able to find and pick our scholarship students for everything from wilderness first responders to nursing degrees. So with our educational projects, the healthcare, with the dental camps, Musa Masala tries to sort of mix everything and round it out to give people in Nepal, especially the young people, an opportunity to get a good education and learn a little.
Musa Masala is a 501c nonprofit organization dedicated to safe, healthy, and culturally aware mountain travel. Our original project is the illustrated book Musa Masala, Mountain Girl of the Himalaya, the story of an orphan Sherpa girl and her life-changing journey to Mount Everest. Proceeds from the sale of Musa Masala, Mountain Girl of the Himalaya, support the Wongchhu Sherpa Memorial Hospital in Nepal, the final dream of climbing and business legend, Wongchhu Sherpa. Musa Masala is proud to be a part of the success of the Wongchhu Sherpa Memorial Hospital since the groundbreaking. A unique fundraising drive brought an ultrasound machine to the hospital. In the spring of 2022, we painted the pediatric room with illustrations from our book. Musa Masala sponsors a week-long free dental camp twice a year in the hospital, providing the only dental care in the area. The Musa Masala Nursing Scholarship Program will award 2 full scholarships each year in nursing or medical technology degrees for students who live in the area surrounding the Wongchhu Sherpa Memorial Hospital. These scholarships will allow for a good future income that will help the family of the student and the community. We are committed to creating striking, portable, and fact-packed educational materials and building on our video library of helpful outdoor tips. The first Musa Masala climbing competition was a smashing success. We have pledged to hold a competition each year in Kathmandu, and in 2025, we will launch an international competition to help bring young people in Nepal into the competitive climbing world. Our passion at Musa Masala is to combine our love of the outdoors and our profession as medical workers while respecting the environment and other cultures. We look forward to seeing our own growth as these dreams of education and healthcare for the underserved and enjoyment of the mountains continue.
Originally, when the hospital was built, so Wongchhu Sherpa Memorial Hospital opened right when COVID hit around, was almost ready 2020, 2021. Our official opening was, we had a big opening ceremony in 2023, but the hospital had actually been running for a year before then. The idea for the dental camps came along when the hospital was up and running, and we were questioning what else can we do for the area that isn't being done for the people that live there. And I met Dr. Anumesh through one of the people that worked at Wongchhu Peak Promotions, which is the trekking company that Wongchhu Sherpa started and had like pretty big fame in climbing Everest and made all these records on Mount Everest. Took a lot of people to the top of the mountain. He was one of the people that started the trekking industry from the Nepali side. And when he died and we were able to open this hospital, Dr. Anumesh went and visited in 2021, and then I was able to start communicating with him on what sort of needs are not being met there. And that's where we came up with the idea of starting these dental camps. The first dental camp was held in 2022 with just Dr. Dahl all by himself. And he brought in, I think we had 300 to 375 patients over 4 days. So one dentist working 12-hour days for 4 days. It was pretty dramatic. It was a lot for him to do. And so we decided maybe we'll bring some more dentists on next year. And all of the dentists that come to our camp are arranged through Dr. Dahl and his Dentist Nepal organization. So all Nepali dentists, the equipment comes from Kathmandu. We try and bring everything else in locally. One of the most important things that we find is we don't bring in 5,000 toothbrushes and give them to everybody in the area, because then the people who sell toothbrushes don't make any money. So we try and go through the local people. We try and keep it all the things that we do for these camps as local as possible. A lot of stuff has to come from Kathmandu, of course. And all the dentists volunteer, and they come out, and it's a 12-hour Jeep ride to get to the hospital. And then they just work and work and work. And then at night, they seem to dance a lot. But we seem to have a really, really good time. I can't believe how much it's grown. So super proud of everything that happens there. We fund these camps. This year's camp was $6,500 for 4 days. We had 700 patient visits. So you can see how hard everybody's working at this. Dr. Gyaltsen Dolpo is the doctor who runs the Wongchhu Sherpa Memorial Hospital. He, along with the entire staff there, makes sure that everything runs smoothly. They all assist. They all help out as much as possible. The staff from Wongchhu Peak Promotion, who comes to organizes everything, Angdiku Sherpa, Fula Sherpa, Binod Bani, Tenzing Sherpa, and the hospital manager, Noang Furi Sherpa, are all working this entire time. Actually, Angdiku Sherpa seems to be becoming quite the dental assistant. So maybe the trekking guide thing, if it doesn't work out, she'll start being a dental assistant. So as you can see, everybody has a really good time. It's a lot of fun, but they work really, really hard. And this is possible for $6,500 because of the way they were able to organize this. So it doesn't take a whole lot of money to make this difference. Nobody else, there's no other dental care really until you almost get to Kathmandu. So most of the people here at this camp have never seen a dentist before in their life. The children certainly haven't. Uh, 2 liter bottles and Mountain Dew are becoming very popular there. So it's a bit of a battle for children's oral health. And when we are able to do these camps, we're finding every time that more and more of the people that live in the area are coming out and they're trusting the hospital, they're trusting us, and it's just making for a very, very good relationship for the Wongchhu Hospital. And then when we do these camps, so it's just been a joy. I mean, it's just really amazing. People are very responsive. We are finding that we had to turn back a lot of people this time. We ran out of supplies. We ran out of fluoride treatments. There were several schools in the area we still weren't able to treat. So as we move along, these are the things we plan for in the future. We want to hold another camp later in the year, so at least 2 camps a year. We want to put some permanent facilities into the hospital for dentistry. And Dr. Dahl and I are working on those sort of issues and seeing how we can bring it all together. But I just am so proud to have met the people I have through this amazing accomplishment that Dr. Dahl has done. Our dentists for this past June were Dr. Anumesh Dahal, Dr. Prayash Dalakoti, Dr. Asmita Gwali, Dr. Manish Prasad Sai, Dr. Pratima Panta, and Dr. Shareya Kansasa. So those 6 dentists have done amazing work. I just want to thank them, and I want to thank our sponsors who helped to make this possible. Musa Masala is a 501c based out of Utah and California, and our donations is how we are able to do this. And you can go to our website for a lot more information at musamasala.com. We also have our Instagram and Facebook, and we have a Shopify store as well where you can buy really cool Musa Masala gear. And I believe when we auction this book off, I'm going to let you take a look at it and see just how really, really amazing it is. I think our illustrator, Julie Ramirez, who's on the Musa board, is actually watching this right now. An amazing artist. Just very, very proud of this organization and what we've been able to accomplish in a short period of time. And that's pretty much what I have. Thanks, Gina. And I'm excited for Anumesh to go all teeth.
Thank you very much, Mike. And for those of you who don't know, Mike is one of the co-founders of Musa Masala, as well as the current president. And he's also an EMS provider that's currently based out of Los Angeles. Now we'll begin the second part of our program tonight in the main event, which is our program about austere dentistry. Dr. Anumesh Dahal is a postgraduate resident in oral and maxillofacial surgery in Tribhuvan University Teaching Hospital, Institute of Medicine in Kathmandu, Nepal. He completed his Bachelor of Dental Surgery at BP Koirala Institute of Health Sciences, Dhahran in 2020, where he actively participated in community outreach programs, providing the basic package of oral care, oral urgent treatment, and oral health education. He is the founder of Dentist Nepal, a clinical and digital initiative promoting oral health awareness through community projects and social media. Since 2021, he's helped to organize Wongchhu Sherpa Memorial annual dental camps at Wongchhu Sherpa Memorial Hospital in partnership with Musa Masala and the Wongchhu Sherpa Memorial Trust. His interests include maxillofacial trauma, reconstructive surgery, and practical approaches to wilderness and austere dentistry. We're going to save our questions until the end, or at least until we get to the case studies. And then after the second half of Dr. Dahal's lecture, we'll answer all questions and open the floor for question and answer and discussion. Also, feel free to type your questions into the chat if you're worried that you're going to forget them, and I'll keep track of them and make sure we address them at the end. So please join me in welcoming Dr. Dahal tonight.
Thank you so much, Gina, for the introduction. Okay, let's share it. Share the presentation.
Well, over the course of tonight, we'll share a couple ways that you can get involved or contribute to the efforts of Musa Masala and specifically the dental camps. So if you look in a chat, there is a link there for you to make a donation if you feel called to do so.
Shall I continue? Shall I start?
Mhm.
Yeah,
Yes,
okay.
please.
Okay. This is the first of all. This is the picture of the Wongchhu Sherpa Memorial Hospital, and these are the kids. They are waiting for the turn to get the treatment. For the for the children below 14 years, we do fluoride application so that they have a stronger teeth to fight against carious lesion and sugary food that are endemic to that area nowadays. Uh, Good morning from Nepal, and I think it's a good evening for you guys. Namaste. I'm Dr. Anumesh Dahal, and I'm currently a MDS resident in oral and maxillofacial surgery. And today we'll be discussing about dentistry in the austere environment. And as I have known that we are from different field, so we'll start with the basic and general idea about the teeth oral cavity, and then we'll move towards the some insight what I have go some insights about how to manage cases, and we'll also have few case discussion, and at the end what are my experience, our experience in the uh, for the because my experience with the dental camp that we have been holding since years in Wongchhu Memorial Hospital. Uh, Now let's start with the basics. Uh, this is a picture of a oral cavity in which a person in which we can see these. This is the upper lip. These are teeth, and behind the teeth there is a hard palate. It's soft palate, and the uvula. Okay, let me turn on the pointer. This is uvula, and we'll discuss if the once we raise the tongue, this is the floor of the mouth, frenum, and in the floor of the mouth there are opening of the salivary duct into the oral cavity, and this is a picture showing buccal mucosa, upper and lower vestibule, and this is where the extension duct, the duct of the parotid gland opens into, and these are how the teeth are arranged in an normal occlusion, although it might not need to be this straight, but this is how teeth are arranged in an occlusion. Next is this is the anatomy of a tooth. The tooth is only 30% inside the oral cavity. Around 60% of the tooth is inside the bone, which is the part of the tooth is called root. The this bone, also known as alveolar bone, which I'll be using this word frequently, so I want you to remember this. And the tooth is attached to this bone through periodontal ligament fiber. There are some ligament, periodontal ligaments fiber, PDL fibers, and through the root apex, the blood vessel and nerve fibers is supplied into the tooth structure called as the pulp. It is a small piece of tissue that makes the tooth a vital structure. So from this pulp, there are different processes that enters into the dentine part of the tooth. Dentine is a if you feel cold or hot during tasting of food, it is possible because of the dentine and the pulp. and everything is covered with a very hard structure. It is one of the hardest structure of the body called as enamel, which protects a whole of the tooth. Now next is the anesthetic agent that we commonly use in dentistry are lignocaine, bupivacaine, and articaine. Lignocaine is the most common one, and we mostly nowadays we only use it with adrenaline. So bupivacaine, it has benefit of longer duration of action. It is almost double that of the lignocaine. And articaine, it has a good bone penetration. So nowadays, in clinical settings, articaine local anesthetic is mostly frequently used. Now coming to the important features of lignocaine with adrenaline. Once we inject lignocaine, its duration of pulpal anesthesia. We in dentistry, we classify anesthesia or the effectiveness of anesthesia. Either it reaches the pulp or it is only limited to other surroundings of tissue. So we want pulp of anesthesia so that while removing the tooth, we do not feel pain. So pulp anesthesia, it gives 1 to 1.5 hours, while the maximum recommended dose is 500 milligram. That is 700 milligram per kg. If it is lignocaine with adrenaline. So using this, the commonly used dental blocks that might be useful in case of wilderness setting could be anterior supraalveolar knob block and inferior alveolar knob block. I have only talked about these blocks because these have maximum range. So learning it would be better so that it can provide anesthesia to a lot of area of the mouth. Except for that, intraligamentary injection inside the periodontal ligament fibers and supra or periosteal or local infiltration, it works good in case of maxillary teeth. Now let's talk about anterior supraalveolar knob block. Anterior supraalveolar, first I want you all to palpate your infraorbital rim, and just below the infraorbital rim you can feel a small depression. Just this is the rim. Just when you end your eyeball, just below there is the infraorbital rim. It's a bone. So below it there is a infraorbital nerve that comes just outside of the bone. So this is the point. Okay, from here. So for anterior supraalveolar knob block, you can directly inject your local anesthetic through the skin over here, or through the through the mouth as well. So if you enter it through the mouth, it will be less what do you call it? It will be less. The patient will be less afraid. Otherwise, if somebody is inserting the needle directly, it might be the patient might be fearful. And next is the inferior alveolar knob block. Inferior alveolar knob block on one side will help us to anesthetize whole of the mandible on the same half. So for this, we need to remember we have to inject the local anesthetic into the inferior alveolar knob just before it enters into the mandible on the medial side of the mandible. So for that you have to take the local anesthetic syringe from the opposite side of the mouth to the corner of the mouth and into the pterygomandibular raphe, so that you hit the mandible in the lingual side. Make sure you aspirate in two planes so that to make confirm that you are not inside the blood vessel. And also do not inject the local anesthetic if you are not hitting the bone. You might have a facial paralysis. Although it will be transient, it might take 3 to 4 hours to resolve, but you might have chance of facial paralysis. And these are the basic blocks, but the most important that works as the backup for the backup is the intraligamentary injection. So for that, we are injecting the local anesthetic between the tooth and the bone that holds the tooth, that is the alveolar bone. For that, you might want to run the local anesthetic agent, uh, run the syringe needle through the tooth into the bone until you feel stuck over there. So once you inject the local anesthetic, you have to inject in pressure. Only 0.2 ml of local anesthetic is required to provide the block for that tooth. And it will be easy once the tooth is removed, you will not anesthetize any other region of the mouth. So it is a good technique, and it will work even when any other techniques fails. Another is the most easiest one, and I think it will be the most useful for you guys. That is supraperiosteal or local infiltration. That is, if you are using it to block the tooth or anesthetize the tooth, just penetrate it through the buccal mucosa, through the vestibule, around just apical to the tooth. For example, if you are just it might be around 1 to 2 centimeter into the vestibule, and you can aspirate and infiltrate the local anesthetic there. Now we'll talk about the sequelae of dental caries. Uh, all these lesions in the green, they are reversible sequelae, so that if the caries on the enamel or only in the dentine, it is easy to manage and the pain are usually reversible. A simple feeling in the wilderness, if the temporization works very good in this case. While if the infection has reached to the pulp, that is the soft tissue part of the tooth, or periodontal ligament region, that is around the tooth, or in the periapical, around the apex of the tooth. So these are the treatment would be to do a RCT, but for if there is a pain and if the pain is severe or if the swelling start to develop, so in this case there will be few techniques for temporization or pain control that we'll be discussing in the later slide. But once the infection reaches into the bone of the mandible or maxilla or into the surrounding soft tissue, so this will be a problem. So for this, in the red, we need to have early evacuation as far as possible. So now we are coming to the main topic, that is dentistry in the austere environment. First of all, we need to know that prevention is the best cure. So before expedition, everybody is suggested to have a dental checkup within 3 months, so that if there are any new caries, lesion, problem in the gums or loose fillings or any other problem, so that can be managed within the 3-month period. And during the expedition, during the travel, it is very important to be disciplined so that we do not develop a new oral lesion. That is, if and the person was already having restoration and frequent munching of sugary food, taking a lot of bars, candy bars, a lot of sugary juices will cause to develop new lesion within the tooth or between the gaps between the tooth and the restorative material. So it is always important to be disciplined and do brush properly and floss. Another thing is use of fluoride toothpaste, and it will be better to use a high fluoride toothpaste during the travel. And next is the dental essentials that we might require for temporization or any managing emergency or urgent care during the field. The first is dental kit essentials include these are the basic things we might have in the first aid kit, that is gloves, headlamps, disinfectant, syringes, lignocaine with adrenaline, antibiotics, analgesic and antiseptics. Except for that, from the dentist point of view, these are few things we need. That are the forceps. There are universal forceps that are available that can be used in both upper and lower arch. There are elevators which will help to remove the tooth, but once you get hand to it, you will not require forceps for extraction. Next is temporary filling materials such as zinc oxide, deuxinol, or IRM. And another is semi-permanent, also filling materials such as glass armored cement. And this will help uh, us to temporize the tooth, control the pain and all. Another thing that might be important is the clove oil. Although we do not recommend it in general use, but in austere environment where nothing is available, clove oil works very well. Other medications, such as for antibiotics, oral cavity is a very dirty place, so we have to uh, give a mixture of antibiotics, mostly covering both the aerobes and anaerobes. And for analgesia, ibuprofen, paracetamol might works good, but etocoxib will provide a longer duration of action up to we can only give once a day if pain is long lasting and severe. Another, as I've said, clove oil. It is made of clove oil will help to soothe the pain as it works as a obtundant material. Now we'll discuss about some common dental emergencies or common dental problems that we might face. First of all, the most important thing is the assessment. We have to see from which level of the tooth the pain is coming. If it is from inside the tooth, outside the tooth, or surrounding the tooth, or from the soft tissue. And also we need to and decide whether the person is feeling pain or if it is just sensitivity to cold and sweet food. And it is easy to localize the pain most of the time, but a few times it is very difficult for us as well. Um, if there is pain in the sinuses around the temporal region, we might suspect it from the maxillary arch. For if it is pain in the ear, behind the ear and towards the neck, then we might suspect it from the mandibular arch. We can also ask the patient to bite the teeth firmly so that most of the people will tell there is a certain teeth that it is painful on biting. Other examination might include percussion of the tooth, hitting the tooth with maybe back of a spoon or a back of a handle, so that we might confirm that that is the offending tooth. So once we localize the tooth and know the level of pain, so now we can we'll see how we can manage them. First is the enamel or dentinal caries. If it is not involving the pulp, that is the soft tissue of the tooth, now which has all the nerve supply and the blood vessels to the tooth. For this case, the patient might feel pain, sensitivity to cold or sweet food, which will last for a while. And on examination, you might see some brown pads over the tooth. So in this case, initially of the fluoride toothpaste or anti-sensitivity toothpaste might help with proper hygiene to keep the food particles away. And if we have gloves and all, we can just temporize it. It's easy. The temporary filling materials, it's some kind of dough, so that you can manipulate a small part of it in your hand and then just place it over the tooth. So it's that easy. And next is the pulpitis and periapical abscess. Although these two are a very different entity during our clinical practices, pulpitis is if the pulp, the soft tissue is involved, and periapical abscess if there is infection around the root of the tooth, but the pain and the treatment will be similar. most of the time. So in this case, the patient will feel pain, prolonged pain on cold or hot food, eating hot food, and patient will not be able to localize pain some of the times. So we have to smack the tooth with the back of a. We do use a mouth mirror, back of the mic mouth mirror or a spoon, any a metallic thing will do, so that we can localize the tooth. uh, we can see, okay, this tooth might be might have a periapical abscess or pulpitis. For that case, if we are suspecting the periapical abscess, antibiotic analgesia will do good. If the pain is unbearable, a block of local anesthesia will help to decrease the pain, followed by a proper analgesics will do the work for us. Next is a temporary feeling along with clove oil can be used to soothe the pain, and in extreme condition, extraction would be our last resort. And if the we can wait for a few days, and if pain control is we cannot able to achieve the pain control, so we might think to evacuate. Next is the abscess. Abscess might origin around the gums, we call it gingival abscess, or from the periodontal ligament or periodontal abscess, or from the root of the tooth due to a necrotic pulp or necrotic tooth. So we call it dentoalveolar abscess in this case. The treatment would be a surgical incision and drainage with a surgical blade, or a poking with a large bore sterile needle would do our work as well. We just need to drain the pus. Adequate analgesic, such as NSAIDs, ibuprofen, would work well, followed by antibiotic therapy. Usually, the empirical therapy would be use of amoxicillin with metronidazole. It works for most of the oral infection. This is the empirical therapy. Next is we might think for evacuation if there is a frank pus and a lot of pus is draining. Otherwise, for a small lesion as such, we can manage with a small needle, and we can manage the pain and infection. Next is the gingivitis. Although it might seem the person is bleeding from the mouth and it might look serious, but this is the most simplest thing to be treated. You just ask the patient to rinse properly and brush properly. That's just the treatment. So for that, you have to see whether there is swollen gums. And the gums are swollen and reddish. These are erythematous. So reddish gums and swollen in the between the tooth, they are the confirmatory signs. So people are asked to brush more, because of bleeding, they tend to brush less, and the problem will only worsen. Next is trauma to the tooth. Usually, trauma to tooth basically include few. So that is luxation. That is, the tooth can be mobile and or tooth can be displaced in a certain place. The whole of the tooth can be fractured, or whole of the tooth can be avulsed, can be knocked out. So I'll be discussing about these three. If once you fall or hit something on the tooth might shift from its place into a different place. We might want to replace the tooth in their position and get it splinted. Once during a health camp, during when I was in Khotang, I remember using the strips of these marks. It has a small wire like thing. We cut it and use wire, 2-3 wires, and we wounded this wire and use as these, and we splinted the tooth with using these wires and zinc glass hammer cement. Mostly we use composite in the clinics, but but GIC works good. The treatment would be to reposition the tooth in place and then provide the splinting. We also have to avoid the tooth to touch each other. If there is interference means while biting the lower tooth, the upper tooth, the fractured or the luxated tooth will start to move. So we don't want that. We want to put the tooth in such a position that both of them do not touch one another. If there is after the trauma, there can be swelling of the lip, bleeding from the gums. So we might want to evacuate as fast as possible. Next is fractured tooth. Tooth can be fractured from the enamel, from the dentin, or including the pulp. If the tooth is fractured from the pulp, we can expect bleeding and a lot of pain. So for that, clove oil can work, or just holding a small cotton piece over the tooth for a while can help to control the bleed, after which we can place a uh, glass ionomer cement. Glass ionomer cement is a magical thing in dentistry. It attached to the tooth uh, on its own, so it can chemically bond with the tooth, so we can use that thing in everything. It works as a bandage to teeth in our case. So after we bandage the tooth with glass hammer cement, you'd like to keep the chipped tooth with you, so that when you go to the dental clinic later on, they can stick the fractured tooth in the same place, so the tooth will be good as new. Although pain and sensitivity are manageable, if the pain is not controlled or start to worsen, so we might need to evacuate. Next is avulsion, that is knocking out of the tooth. Uh, Usually, the front tooth that can be knocked out because of its conical shape during a fall or any small minor injury to the face. In that case, the first thing is to control the bleed with applying the pressure with a sanitized hand. Always remember, if the tooth is inside the mouth or has not displaced outside, so you can just replace it. Or if the tooth fell into the floor or in the ground, so always hold the tooth through along the crown. Give a good rinse with normal saline, or if milk is available, and try to reimplant under local anesthetic, or even under good analgesic such as ibuprofen. If it is not if we are not able to replace it, uh, store the tooth in a cold milk, normal saline, or if nothing is available, then you can place the tooth in the patient on cheek, so that you can reimplant when you reach to the dentist. It is always, if you do not if you are okay with missing a tooth, and you can continue the expedition, otherwise you can reach to the nearest dentist and replace it once you reach them. Next is parodontalgia. It is nothing but pain when the pressure in the altitude has changed. So pressure in the environment has changed, because of which the tooth, they are kept in a very tooth. It is held in a very close compartment. So when the pressure in the environment changes, you might feel some pain. Usually that can be managed with analgesia. Analgesics such as ibuprofen or paracetamol. If the pain is severe, we might consider descent as much as possible. Usually these conditions are not urgent. Next is temporomandibular joint disorder. We might face this problem in older population, where the joint, it has been loose, the laxity of joint can be felt. Clinically, you will see the patient will not be able to close their mouth shut. Or in if old cases, the patient while will not able to close the mouth shut, and maybe on one side, and on the other side the joint might be normal. So we can see a hollowing over the preauricular region, just ahead of the ear. For that case, this is the Hippocratic maneuver that we call. It is how we treat the dislocation. Push the mandible downward, backward, and upward. Um, this is the most easiest way to do it. Although there are many other techniques for reduction of the mandible, this is the most easiest way to learn it. So it's just that pushing the mandible downward, backward, and upward. We have seen a case where there was an old lady from Dolpa. She was like maybe 3 days away from us. And at that time, when she faced the problem of the temporomandibular joint dislocation, by the time she reached to us in teaching hospital, it was already 2 months. And it was because people are and local doctors, they were aware about dislocation of different joints, but dislocation of mandible and reducing it, uh, the information about this is very less among the people. That's why I want to share this with you guys. Next is maxillofacial trauma. Any trauma to the jaw or zygomatic bone, trauma to the nasal bone and all, might require immediate evacuation. Clinically, you might suspect a fracture if there is the fracture portion is mobile. You can move the fracture portion with the hand, or there can be a lot of bleeding from the oral cavity or the nose. Usually, fracture of the orbital rim, cheekbones will have a bleeding from the nose. So you might want to see them. Next, let's do a case discussion. For this case discussion, I want you all, if possible, to unmute. Is it possible to unmute, Gina?
Yeah, it is. Anybody can mute or unmute themselves and turn off their camera and participate.
Okay. First is, can anybody volunteer to read this case discussion? Otherwise, I'll volunteer.
Sure, I'll do it.
Okay.
A 28-year-old climber on a 2-week Himalayan trek developed severe throbbing tooth pain on day 5. No obvious swelling, but he cannot chew on the right side. Wakes at night from pain. No dentist within a week's travel. Medical kit includes ibuprofen, paracetamol, amoxicillin, clove oil, temporary filling material, IRM, local anesthetic with syringe and lidocaine.
Okay, thank you. So what would be our working diagnosis? Because of the throwing nature of the pain, and patient wakes during the night, and patient cannot chew from the same side, so we might think it is a pulpitis type of pain. So the first line for the pulpitis would be analgesics. Okay, I think I'm going
I think it's the pulpitis and not just like a high altitude
yeah,
pain.
it will suggest the diagnosis would be, working diagnosis would be a pulpitis.
Okay.
So the first line would be for pulpitis,
Analgesia.
the first line, analgesia. Yeah, then if even with the analgesia, if it does not work, if the pain persists and he cannot function, what is your second line option? Is to temporize, to use a clove oil, and then use a IRM, temporary filling material. And what would be the last resort if nothing works?
Evacuate.
Yeah, okay. Extraction was the option.
Extraction.
Yeah. Yeah, in case of if the pain is severe, yeah, we might extract. And then the last and the most last would be the to evacuate if the pain is not controlled.
What would
And
you use to do a field extraction?
I remember Everest DR 2016. There was a field extraction of a tooth at Everest DR by the doctors there, and it was a porter who came into the ER tent with pain, and it's just a kind of remembrance from everyone who's on a trek or who's doing any sort of field work or expedition work. The people who are there around you, not just your definitive team, can also run into all these problems. So it's always good to check in on everyone. Make sure everyone's staying healthy that's in your team, whether they're a porter or a guide or part of your organization, because a lot of the people who are traveling with you can run into these same kind of problems and other health problems as well.
Okay, let's go to the second case. A 19-year-old trekker. Would anybody want to volunteer for this case? Case 2. Okay, I'll continue. A second case is of a 19-year-old trekker who slips on the rock and falls her face first. The upper front tooth is completely able. It got knocked out. It's only 20 minutes since the time of the injury, and you are 3 days from the nearest dental clinic. What are the the kits available to you are normal saline, gloves, splinting materials such as aluminum foil or any strips, and glass enamel cement. So what would be the first step?
Rinse with saline the tooth.
Yeah, first is to control the bleeding from the oral cavity and rinse the tooth. Just hold the crown and rinse the tooth. And what would be the best immediate management for the tooth, for the knocked out tooth?
To
Pop it.
Back. Yeah, that is the best thing, because we have to keep it where it belongs. And once if we are not able to pop it back because of the pain or any fracture associated with the bone, so if reimplantation is not possible, what are the storage options? How can we store the tooth?
in saliva.
Yeah, in saliva or milk would work good. Actually, the main agent would be Hank's basic salt solution, but I have not seen it till now. So, because it will not be possible to have it everywhere. So, what are the options to splint the tooth in the place? Once the tooth is kept in the place, it needs to be splinted. What are the options? How can we splint?
Well, I think part of the stuff that she had was aluminum foil, so make like an aluminum foil
Yeah,
routine.
aluminum foil. Yeah. Now we can roll the foil, or keep it, or just like you have said, just use an aluminum foil as the retainer so that it can and do we consider evacuate or we can continue?
Good to continue, right?
If if it has been splinted well, then we can continue. Otherwise, it might require evacuation. Now, okay, this much was the academic session. Now we'll discuss about our experience during the health camp in Musa Masala Hospital. Sorry, Wongchhu Sherpa Hospital. All these camps we did with Musa Masala and Wongchhu Memorial Trust. The hospital is based on Solukhumbu, as Mike G has already said. It is remote. This place we reach, it will take around 12 hours for the travel. And within 4 days, we provide around 700 treatments to the people. So mostly we do tooth extraction, filling, that is, we do atraumatic restorative technique, ART filling, scaling, and dental X-ray, which was possible from only through during few years. Dental X-ray were possible. The we manage the patient volume. We divide time for each of the region, so that this was the technique that was brought to us by Dr. Galson, because some of the time we feel that on the first day of the health camp there were a lot of people, and even though we were 4 dentists or 6 dentists in last time, we were not able to uh, treat the patient, everybody in the first day. So we try to divide the location of the location, and ask the patient to come us. We send the information through radio a few weeks earlier. During that time, all the members of the hospital of this primary healthcare center are the part of our dental camp. So everybody is busy in managing the people, taking to different places. There's we Last time we have set up 3 rooms for the clinic, for the dental, as a dental clinic, in which one room was for dental extraction, one was for filling and restoration, another filling, restoration, and cleaning, another one was for pediatric care. We have a periodontics uh, with us who is very glad to help and take care of all the children by on her own, but we do help her with our cases. And around 30 to 40% of our we provide care to the children, because in these villages most of the youth, the working population are not in the village. Either very old people are there or very young people are there. So the most common case that we see are dental caries, dental abscesses, and periodontitis, gum diseases. Most of our treatment is focused on basic package of oral healthcare, which was provided by WHO, and also emergency intervention as and when required. This is a typical setup of our dental camp. This is a makeshift dental chair, keeping the patient, although with the position might look very difficult. Uh, so this is how we keep the patient in our lab, so that it is easier for us to access the oral cavity. So I think here restoration was being done, and I think the restoration has been completed, and she's checking if the restoration is in place or not. One very challenging thing is, since uh, we are taking all the stuff from Kathmandu uh, to the hospital, we do not know for sure how many people will come to us. But interestingly, every year we are providing more treatment to the people. Uh, we have started from maybe 300 treatment earlier, and now we have come to 700 treatment. Because we have more team, we are more planned, we are more organized nowadays, but only the treatment needs has been increasing for the patient. There was a old couple, I remember a old couple who were not able to go to get a definitive treatment. So they were very generous to come to us and to get treatment from us. And the problem was that they have a lot of problem in their oral cavity. So we were not able to take care of them in one setting. What we did, we requested them that because we were there for 4 days, so we asked them to choose the tooth that are more offending. So if somebody has problem in 7th tooth, maybe if we are able to remove 3 or 4 tooth within 4 days, it would be it will help them to ease with the pain, but it was sad from our side and sad to the patient that we are not able to provide treatment as a whole in a holistic way. That is also a very sad thing. So setting up a setting up a dental chair there and keeping a dentist over there would help such cases. uh, Also, for sterilization we use autoclave. But the autoclave, I'm not proud, but we have blasted two of the autoclave because of the how frequently we have to use it, and because of the volume of the people. I think once in 2021 and once previous year. So we have blasted. So now it is good because they have brought a bigger autoclaving machine. Thanks to all the donors that have helped for that. And if between that, if we are able to do, if we also use Cidex glutaraldehyde, which is a disinfectant, high level disinfectant, which will help uh, for the instrument that does not require blood works. Uh, as I've said, logistic will be a problem for supply because we don't know how many patients are there. Sometimes we might get short of the medication, so we provide the medication in such a way that those people who are in need, are dire in need, will not be missed out of the medications. And the cultural aspect is also challenging for us. I've written drunk man over there because in that community, it is a casual thing to have a morning uh, alcohol as a tea. So, we request them. Initially, it was very difficult for us to make them understand that this alcohol will hinder the treatment, hinder how local anesthetic works, how medications such as metronidazole work with them. So providing a treatment to them during that time was very difficult when they were drunk. And when we asked them to come on another day without getting drunk, so they would accept it, but next day they say that they have reduced the amount of alcohol to half, but they come drunk. So it is very difficult for us to uh, initially, in earlier days, it was very difficult for us to manage that. But now, because Dr. Galson is there and he is constantly reinforcing the people what are the ill effect of alcohol, because the alcohol they drink, they are prepared in the home, and sometimes those alcohol are might have methanol in them, so that might also be poisonous. So Dr. Galson, occasional drinking is good, but regular drinking is very detrimental. Um, I would also like to share a few lessons that we have learned that uh, we try to give our best in the camp. We tried to give best with whatever the resources we have. Uh, the main thing is that we try to listen to their problem, listen to what they want, and make people assure that we might not able to provide everything, but we will assure you that we will do what we can with all the things we have. And we always prepare for the worst. We also, for the health camp, we also carry sutures, uh, tranexamic acid, steroids, adrenaline source in case we face with the emergencies. We do have specialized periodontic care who because as we see there, the most the group of people that need the treatment most were the children below maybe 14 years because of Mountain Dew endemic, as Mike G have said. Everybody, as the children as little as 3 years, 4 years, have a bottle of Mountain Dew in their hand and they drink it anytime without taking care of their oral cavity. So I think Dr. Galson has been very generous to inform all the people how this habit should also be changed. And further, next, there are always areas for improvement. We have been removing teeth of so many people for whole of this year. For the next camp, we want to put prosthesis to them, and a longer health camp, and also increasing the frequency would be a good thing so that people will get more specialized care. I'd also like to request, if you guys want to join, we can manage something with with Mike G, if it is possible, for all the people in this Wild Mid Wednesday, so that we can help, or we can go there and be a part of this camp. Thank you. This was uh, what I have to present. I'd also like to thank Musa Masala, Wongchhu Sherpa Memorial Trust, and all the dentists of Dentist Nepal that were with us. Uh, like in the first camp, Dr. Megha was there with us. In the second camp, Dr. Abhinay, uh, Dr. Kritisha, and Dr. Asmita was always with me. She's my wife, along with Dr. Prayas, Dr. Manish, and uh, whom I miss. They'll kill me if I miss their name. And Dr. Pratima. Thank you
Dr.
everyone for
Kaisa?
helping us. Yeah, Dr. Prayas.
Okay.
Prayas. Thank you all the people who has helped us to make this possible, and thank you, Gina, for providing this stage to share my knowledge and my experience. Thank you. And we are open for the question.
Thank you so much, Dr. Anumesh Dahal. Absolutely incredible presentation. We had a lot of requests that if we could get a PDF of your slides so that I can share them with everyone who attended tonight. They found them very useful, very helpful. So maybe we'll talk about that after.
Okay, I'll do it.
Cool. You're definitely a wealth of knowledge and experience. And I loved how you broke out the categories of like, should you evacuate or not, and like the tips. That was awesome. Really practical. I know for all of us, when I say that we feel very fortunate that you shared your teaching and experience with us tonight. Before we open the floor to questions, we'd like to do a special giveaway tonight. Mike has generously donated a copy of their book, Musa Masala, Mountain Girl of the Himalayas, that you can find on their website. I'll share that in the chat right now.
Visible.
Yeah. Dr. Dahal, if you will stop sharing your screen, then it'll make Mike's screen bigger. So
Okay. Sorry. I'm sorry for that. Yeah.
Okay. So yeah, this is the original. Our original project for Musa Masala was the fundraising book for the Wongchhu Sherpa Memorial Hospital. And it's an illustrated story of a young Sherpa girl who becomes a climber. So this is the first book in a series. It's kind of based on the life of Wongchhu Sherpa, who was an orphan boy who went from being a porter to a cook to an assistant guide to a mountain guide to running his own organization to holding. I mean, he had the record for sleeping on the summit of Mount Everest longer than anyone, which is a kind of a bizarre record, but if that's what you want to do. But he really was he was the guy who started it for the Nepali people in the guiding industry, and he was the sirdar for the IMAX film. If you guys remember the Everest IMAX movie with David Bashirs, he was always worked with David Bashirs, who was a friend of Musa Masala also. We miss David a lot. And the Wongchhu story is just an amazing story. So we kind of wrote it into this book. And it was illustrated by Julie Ramirez, who is a member of the Musa Masala board, an amazing, amazing artist. So we'd love for you guys, somebody here to have that. And Those of you who don't win it, I'm very sorry, but you can go to the website and get one for $30.
And
Thank
all
you, Gina.
proceeds benefit your mission.
Yeah, especially every cent from the book goes directly to the Wongchhu Sherpa Hospital. So that's our original project, and even still, several years later, we still donate all the money to the hospital.
Additionally, you do not need to reside in the US to be a recipient of this prize. Mike will mail you a copy of this book anywhere in the world if you're the winner.
Come on, Singapore.
Yeah.
You already won one, though.
All right. I'm spinning the wheel. You must be present to win, though. That doesn't change. I am going to butcher your name, and even though you just emailed me, please tell me how to pronounce it. Negin Khosravi.
It's Negin. You're fine.
Thank you.
Thank you.
Oh, I'm so happy you won. You've been joining us like every single month for like a year now.
Hey, Julie.
Thank you.
Email me at wildmedwednesday@gmail, which I know that you have that now, and we'll get you connected with Mike so that you can get your prize.
Sounds great. Thanks.
Yeah, congratulations. Thank you so much for being here. It's amazing.
We'd now like to open the floor for questions, not just about tonight's topic, but also about Dr. Dahal's journey through his dental camp experiences, even dental education, if that's something you're interested in and you're early on in deciding your medical pathway, logistics of organizing and hosting dental camps, or any event that Musa Masala might participate in. I know I had some tech difficulties sharing that video, but they also host a really cool climbing competition locally every year to benefit the local population. And Dr. Dahal did share with me that he'd be really eager to compare dental care and experiences with anyone who's willing to share, because he's curious to learn more about dental care outside of Nepal. So feel free to drop your questions in the chat or come off mute, come on camera, and let's keep the conversation going. One question that someone did email me even before tonight was, should clove oil be carried in your dental kit? And you addressed that right off the bat. So I thought that was pretty cool. You've really seen good analgesic properties with just clove oil.
Okay, I'd like to add more because clove oil, although we do not commonly use during our clinics or any other places, this clove oil have a good obtundant analgesic effect for the tooth. If you have to use it with caution, because it is generally not recommended in general to other people, because it might burn the local mucosa around the tooth and even the tongue if it goes elsewhere. So you have to use it little with caution. But yeah, it can be used. It works good for the control of the pain. People have been using it for a long period of time, but it should be used with caution. It does very good for the control of the pain.
Does it have any antibacterial or disinfectant properties, or is it just an analgesic?
No, it actually it does not work as analgesic. It necrotizes the tissue around that place, so it burns the. It has burning, more like burning property. It burns the nerve endings of the tooth, so that it kills the tooth and it will not cause pain. So it should be used with caution. So I'm only sharing because you guys are medical people. I ask general people to not use it and avoid using it because these are the dire emergency. Even our Nepal government supplies it to the hospital for free in the earlier. So nowadays it has been reducing. The use has been reducing, but in those situations it works very good. It's like a two-way sword. You have to use with caution.
Another question that someone typed in the chat earlier after you mentioned if you inject lidocaine into a blood vessel, it can cause patient paralysis. So they were curious, the extent of the paralysis and how long that paralysis might last. Specifically, is it permanent?
Okay, no, I think the two things have been confused. Injection of local anesthetic into the blood vessel will not cause paralysis. Injection of the into the blood vessel might cause anesthetic toxicity, local anesthesia, lidocaine toxicity to the body, and the adrenaline in the body might raise the blood heart rate for a while, and it will come to normal. But injection into the soft tissue will cause facial paralysis because the parotid gland that sits here over here, we might through while injecting the local anesthesia through the mandible, if we go behind the mandible and if we are not hitting the bone, we might inject the local anesthesia to the facial nerve in the parotid gland. So we might paralysis only the branches of the facial nerve and not whole of the body. So thank you for opening up. I think I have made you guys confusing about this, and these will work only till how long the local anesthesia work. For the soft tissue, it's around 3 to 4 hours. So after 3 to 4 hours, once the action of the local anesthesia wears off, the people will be normal. So it is a transient facial nerve paralysis. So it's just a transient.
Dan asked in the chat, what should clove oil be combined with?
Usually clove oil, the clove oil, we do not need to combine it, but soaking the clove oil in a cotton, a small piece of cotton, and keeping it inside the cavity, and then sealing off with a simple cement. That is the dough. We can mix the cement. It comes in a dough, like a dough, and we can roll it in the hand and make a small pallet and put it inside the cavity so that it will not spread inside the cheek or the tongue. So it is how that it should be used. Just keeping it there will wash it with the saliva, so it will not work.
And I was going to ask one other question. I feel like I love to put super glue always, and I thought you said something about super glue, and I was just curious at what kind of longevity it has in the mouth. If you did say that, but if you didn't say it, I hallucinated it. So
actually, there was super glue in one of my slides. The super glue, it is acrylate. It is made of cyanoacrylate. So we have with a word of duct tape in the color, right? No, with the wire, it does not actually sticks good with the metal. But super glue, if you can put in the teeth, it will stick to the tooth because most of our composite, it is made with the same material, that is acrylate. It has some of the properties of that as well. So it sticks there, but it will not be a very long-lasting joint. Connection. It might works for the wilderness, and it works best when a person has a denture, and if the denture has split or fallen out, we can stick the denture with the super glue. It works very well, at least for maybe a few weeks or to the months. It works well. For the denture, it works more than the teeth.
cool. Thank you.
Another conversation and also a curiosity of mine in the chat is, what kind of tools do you use if you have to do a field extraction?
Field extraction. Okay, we use dental forceps. There are universal forceps available, but for maxillary tooth, a straight forceps. Do I have to share it? Because forceps, you can carry one forceps for the maxillary arch, one for the mandibular arch. So you do not want, although it is best if we remove all of the tooth, only removing a part of the tooth will work for pain control.
I just Googled picture of those in
Yeah,
those.
forceps. Yeah.
I have a question. Dr. Dahal, I'm curious about your current situation in Nepal. I know Nepal recently went through a challenging government transition. So how has that impacted your work, the hospital, and how are you doing as a human being?
No, even we are amazed because this protest, it only took place for 2 days. The government had changed and it was replaced by maybe more popular government because our country, we have been seeing same people for a long period of time, same people, they were ruling, they are taking turns and ruling and not improving the condition of Nepal. So I think that we are hoping for the best because now less corrupt people are in the lead, but they are not permanent. They are only here to stay with us for a few, maybe 6 months, and there'll be a new government will be formed. So let's see, we are very hopeful for that. And during the protest, there were many gunshots. We were able to remove bullets from the face of the people and the mouth. So it was quite an experience.
Wow.
So everybody is well. The people who we treated were well because yeah.
So they would call you in for dental consults for facial injuries?
Yeah, but I am studying maxillofacial surgery. It is a different field. We treat whole of the face.
Oh, okay.
So we everything comes under maxillofacial surgery. Facial trauma, mostly all the facial trauma comes in maxillofacial surgery.
And you receive those patients in Kathmandu in
Yeah,
the central
we
hospital?
see in Kathmandu hospital, in teaching hospital.
Well, thank you for doing all that, saving people, healing them. Really impressive. Appreciate you so much.
Thank you so much. I do not know how to react with, but that is my job. That is how it is.
I know that jam jam is a popular phrase.
Praise.
Can you share what that means, the use of it with everyone? Because you use it in a lot of the Musa Masala videos.
Yeah, Anumesh, you want me to do that?
No.
You do it? Okay. Yeah, it came from it means let's go in Nepali. So that's kind of our little tagline because in when we were climbing on climbs and everything, it's always come on, jam jam. And there's jam jam and then there's bastari, which is like slow down. So yeah, so we everything with us is jam jam. Let's go, let's go, let's go. So that's where we put it on everything.
Yeah, but even the name Musa Masala is interesting thing.
Yeah.
Because in Nepali, Musa means a mouse. In the logo, they have mouse, and masala is spices.
Yeah.
So it's a weird combination.
I could
So,
love it.
Yeah, actually the name came from a mouse was crawling all over my head in a mountain hut, and all night long I was trying to get rid of this mouse, and we had just seen Lama Geshe, who is the head lama for the whole Everest region. He gave us this big long speech for 30 minutes, and I said, "Well, what did he say?" And he said, "Be nice, don't hurt things, don't kill things." So I was gonna get this mouse, and then I figured, oh, Lama Geishi's gonna be so mad at me. So I opened the door and let the mouse run outside. And then the next morning, I told all the guys, and they all went Musa, Musa, Musa. So that's where the Musa name came from. And then we like to do lots of different things and spicy. So that's where we get the masala from. So that's how we got our name.
It's a name that just like rolls off the tongue in English at least really well. And now it's even cooler knowing what it translates to.
Yeah, so it's pretty fun. And like when I met Anumesh and we start talking, and then we have like some common ground. And the first time I actually met him was at one of our climbing competitions,
yeah.
because we just kind of keep passing by. It's really difficult to get to the hospital. It's difficult to get there at certain times. So we talk a lot, on WhatsApp and Facebook and everything, but it's really hard to actually get to meet. So we haven't even met at our dental camp yet. We meet at the other Musa type things that we're doing.
Okay.
So
Lee asked in the chat, are there any teeth supraperiosteal won't block if it is localized to one tooth, such as the molars?
Yes, yeah, that is a very good question. Usually, the local infiltration or the supraperiosteal injection won't work in whole of the mandibular arch, except in the anterior teeth. It might or might not work because it has a thick bone around the tooth. So this thick bone will not allow the local anesthetic to penetrate inside. But in maxillary molar, only in the maxillary first molar, it might or might not work, but most of the time it works. So yeah, so for lower block, for the lower teeth, it is good to do a inferior alveolar knob block. Otherwise, supraperiosteal will do everywhere. And if you are not able to anesthetize with the supraperiosteal knob block, always intraligamentary will always work, because all the tooth they have ligament, periodontal ligament fiber, so we can always block with the help of intraligamentary injection. I think I am able to answer your question.
Dan asks, would you say or trauma is the biggest enemy to dental health that you see?
I would not say either of those. I would say not taking care of the tooth is the most biggest enemy to the dental health, because even the amount of sugary food, the quantity will not be the problem, the frequency will be the problem. If I take maybe a big chocolate, a big Cadbury, and eat everything at once, my teeth will be exposed to sugary food only once. But if I take all the 10 blocks of it and eat it 10, a small piece of the chocolate 10 times, so my tooth will be exposed to the sugar 10 times. So doing a proper rinse to the oral cavity and flossing, and during night time taking care of it will be taking not care of it is the biggest enemy for me.
That was a good question.
Yeah, that is a good question.
so eat all the chocolate, write it all at once.
Yeah, eat all the chocolate at once. Be greedy.
I can do that.
What if we just brush the time we eat?
Brush.
Yeah, if we like brush our teeth between each time we eat candy, then we can just eat it as often as we want to.
No, but there are also downside of brushing very frequently. You will erode all of the enamel, and there is a phenomenon in which after maybe 20 minutes of eating a food, our oral cavity, it gets a little acidic. So this acidic what that cause tooth to get eroded. So every 20 minutes, if you are eating it, so your teeth will be exposed to the acid whole time. So every time you will be exposed to that, so the tooth will get demineralized and get eroded. Because teeth is made of mainly of the calcium and magnesium, organic calcium phosphate. So they are very prone to erosion with change in the acidity of the mouth. pH of the mouth, sorry.
Tried to find the loophole, guys.
Yeah. That's
I think I'm still gonna
yeah,
eat all candy at once. I can only do it so often. You know, I have type 1 diabetes, so
Do it all at once. Does anybody have any interesting dental things they've seen in their work or anything, and how they treated it that they'd like to share with Dr. Dahal? Maybe there's some differences between where.
yeah, I'll be very eager to learn the practices, and I can learn from you guys as well.
And I had a dental avulsion. I didn't know what to do.
Okay.
I had no idea because it was after a crash. So I'm a paramedic, and
Okay.
it was so from the canine to the second, I don't even know the name of a teeth.
Okay.
So counting from the right side of canine, from the anatomical position, it'd be 1, 2, and 3. And the 3 teeth were avulsed,
Okay.
and I didn't know what to do.
Okay.
Trying to
Now,
pack it as possible, kind of kept the area moist. I didn't push anything back in, but kind of kept it packed, and then
okay, wow.
to a maxillofacial surgery. But I had no idea how to deal with that, like with 3 avulsed teeth at the same time.
Okay. Yeah, because one thing is that if there are multiple teeth avulsed, we might miss the orientation, which tooth is which tooth is in. It will be just like a puzzle. So you do not know where to keep it back. And usually, if was where all of the tooth they came out, or they were inside the oral cavity, the avulsed tooth. Did it fall down?
Only the canine fell.
Fell down. Okay.
The other 2 were still
Still
with.
there. Okay. So that means, yeah, you could have placed it and asked the patient to hold it for a while. How far was the dentist, maxillofacial surgeon?
Like 36 hours away. I
Oh,
worked in a very different
remote area.
area. Yeah.
Okay. Wow. Yeah, if you have kept it moist and inside the oral cavity, I think they did a great job there.
About how long I'm imagining like amputation or in the case of avulsion, how long would you expect the tooth to maintain, be like stay, I guess, alive or stay viable to replace?
No, tooth has very small nerve fiber, nerve and blood vessels, so
Oh,
tooth will not be alive once it has been knocked out. So basically, while we place the tooth back, we want to do it within, uh, course, the best time is within 60 minutes. We do within one day, that is 24 hours, but the chances of root resorption, chances of not the tooth being infected will be more. So the best time is 60 minutes. So that's why it is always advisable to push it back as in when possible. If it is done as early, so although the tooth might be non-vital, but the supporting ligaments, the periodontal ligaments, will hold the tooth in place. Yeah. So that we want the periodontal ligament to hold the tooth back. So for the vitality part, we have to do a RCT, root canal therapy, later on. So root canal therapy is like we make the tooth non-vital and keep the mummified tooth in the oral cavity.
That's a good question.
Yeah, I think a lot of good questions are coming.
I don't think I've like seen a lot of dental stuff other than just dental pain, like a generic toothache. And usually in those situations, I had lidocaine available to me, so it just have just done a basic dental block. And luckily, no one like went on to like get a fever or facial swelling or anything that necessitated a more urgent response in my time with them.
Yeah, wow.
Just luck, though. I've now learned.
Yeah, no, yeah, because oral cavity has so many normal flora that it is very hard to get infected, because oral cavity is very resistant to infection. It does not easily get infected because it already has a lot of microorganism. It usually does not get infected, but even because of which dental treatment I see in our place and locally they have very poor sterilization. Even then, nothing happens. So we are worried about that, but because they get out without any consequences. Yeah, that is the very great benefit of oral cavity.
Could you I'm sorry I'm fixated on this field extraction thing. I've learned I have a new worst fear tonight. Could you just like use lidocaine and pliers? Like, you're not always gonna have dental forceps.
Yeah, yeah. If you have disinfected it well, and if it is sterilized, if possible, but if it is disinfected, we can use. And the aim is not to remove whole of the tooth in the field. We just want to remove the pulp from the surrounding tissue so that the tooth become non-vital. Like the tooth might get, as the tooth got avulsed, we just want it to not painful at that time. So if any things are remained, it can be left there and they can do a treatment later on.
Okay. In parts of Nepal, is normal dental care like going to the dentist twice a year? Because I know in the United States, it's recommended to go to the dentist twice a year for dental cleaning, and they check you for cavities.
Yeah.
Is that kind of the
It
same?
is no, usually people do not come to us when the lesion are small. When I used to practice as a dentist earlier, I practiced in Khotang, which is itself a remote place. So at that place, people were so resistant to like dental caries and all. They would only come up to us if they have a big swelling, if they are unable to open their mouth, and only the problem has gotten worse, and now they cannot tolerate it. Uh, I have seen so many patients, they have tried to pull the teeth out with the pliers, as you have said. They try to pull it out with their own, and later they come. But if you pull the tooth, it will not. The problem will be solved for maybe a few months. But after a month, there can be some swelling or the pain can reappear because of the infection to the surrounding structure. Uh, and now it will be to us that we have to take care of that. Yeah, because if once the tooth is out, if the root is remaining, most of the time nothing happens. Some of the time there can be swelling. So people do it to it themselves, and they will stay. They think that the treatment it is the ultimate treatment, and they stay in home without any problem, and later they come to us. So it is both ways, like that I've said about the clove oil. It is good emergency treatment, but in Nepal people do as the permanent treatment. So that is where the problem is. We have to make sure know what is the emergency and what is the actual treatment.
So if people wanted to know how to get involved, I know we talked about this a little bit earlier and a couple people were mentioning it in the chat. What are ways that they could contribute to or get involved with the work that you're doing?
I think Mike G will be able to tell it nicely.
Passing it on, eh? Yeah, so uh, there's a couple different ways. The Wilderness Medical Society does a yearly trek, usually to the Wongchhu Sherpa Memorial Hospital. This year it was canceled because of the overthrow of the government, and right now there's a travel advisory that won't allow the WMS to send the trip. But they will do normally an Everest Base Camp trip once a year, and then they do the Wongchhu Sherpa trek. So you can go through Wilderness Medical Society. The organization that facilitates all their trips is Wongchhu Peak Promotions. It is run by Lakpa Sherpa, who is Wongchu's daughter. Lakpa also is the chairman of the board of the Wongchhu Sherpa Trust. She runs the hospital as well. So I think she's barely maybe 30 years old. She runs a hospital, she runs a trekking company, and she runs a major nonprofit in Nepal. So she's one of the most amazing people I've ever met. Her team at Wongchhu Peak Promotions, Angdiku Sherpa, Fula Sherpa, Tenzi and everyone else there are just absolute professional trekking and mountain guides. They are probably some of the best people you want to go to if you're considering going to Nepal. When Musa Masala does our treks as well, we always go through them. We have done we've done special. We did a special painting trip where we painted the hospital, so the interior was like the book. So there's a whole room in the hospital that's done up in the interior of the book. And Julie Ramirez, who's here, she supervised. We had 5 painters come out from Kathmandu with Julie, and we spent a week painting the hospital. So there's things that we do that, and I think we want to try and do that again pretty soon. If there's interest, we would certainly bring some people to the dental camp, which it was in June of this year. There will be one in June of next year. The question is, if will we do one before then? But any interest, you can contact me at Musa Masala through our Instagram or Facebook or our website, and I would be happy to talk to you about, being involved, just going to Nepal in any sort of way that you'd like to go as well. We just have a lot of really great friends there who can make that to be a wonderful thing for you. And if you're interested in donating to Musa Masala, you can go to our website as well. You can go through our Shopify store. You can even set up monthly donations, and everything you do, a $25 donation basically allows us to buy toothbrushes for entire schools and toothpaste. So a $25 donation is $250 in Nepal. So you can see how we're able to do things and keep it with the people who live in the area as well. So does that kind of answer that kind of question? Yeah. Okay.
I have to add, I was so amazed that to hear how costly the dental treatment is in US. I heard that one of my acquaintance, he extracted only 4 tooth for $6,000, and we were able to do maybe 700 teeth in $6,500. So
Yeah.
I think it multiplies on more than 500 times over here. So
Where do you put all those teeth? I've never asked before, but I just kind of, where do all the teeth wind up? 700 teeth, where are they?
actually, earlier I used to export it to Bangladesh because because my wife was studying there. So uh, it is very interesting that our tooth is a whole organ. A single tooth is a single organ. So we might, as a dentist, we are very eager to have those teeth, so that we can practice
Oh,
treatment in them, and then later do in people.
Cool.
mystery
Yeah, because we
solved.
provide it to dental students.
Okay.
Provide it to dental students. Yeah.
I was just afraid to ask. I've never asked before. So
No,
I
no.
got asked in a big, huge group of people.
Yeah, but among most of them, maybe 90%, they are not protecting, they are not keeping. Only maybe 10% we extract those teeth that can be reused for studying purpose. Because all those other are very decayed and small fragments only. So that cannot be, that need to be thrown out.
Okay.
Are there any populations or different religious groups that you treat that do want their teeth back for religious reasons? Because like I ask, because in what my surgical specialty, part of it is doing amputations, and certain religious groups need their limbs back and they bury them in ceremonial rituals or even have them preserved at funeral sites so that all of their body parts are buried with them when they die. And I've heard of them asking for their teeth back as well. A lot of our Native American populations hold these beliefs here.
Yeah, especially in the children, the belief is that if they uh, the tooth, if they cross a roof of a home, we call it duri. If they throw out beyond the roof of a home, so that the new teeth that will come will be a healthy tooth. And some also believe putting it in a dung and protecting it that can be used later on, but that we do not follow it. nowadays it has been decreased because when I was a child and I remove all my deciduous tooth, we used to throw it as far as we can.
Does the tooth fairy exist in Nepal? Have you
No.
heard of the tooth fairy?
Yeah, I have heard tooth fairies uh, through the cartoon that we saw in earlier times.
The tooth fairy is very important here in the US.
Okay. Yeah, because we get a lot of money, I guess.
Yeah, I don't know. I guess it depends on where you live, but we got like $1 or like a can.
Okay.
Well, thank you again very much, everyone. We'll sign off for now. Email wildmedwednesday@gmail if you want to get involved or have any questions. We'll get that recording out as soon as I'm able to and link some slides from tonight. And we'll see you next month.
Thank you so much, Gina. Thank you, guys. Julie, can I see you? Anumesh, bye.
Bye-bye, Maxie.
Bye.
Happy Thursday to all.